Good evening, everyone, and welcome to tonight's FDU Alumni Webinar Series, sponsored by the FDU Alumni Association and the Office of Alumni Relations. As always, we hope everyone with us this evening is doing well, and we thank you for taking your time out to join us. I do want to take a quick moment to give everybody some tips for your optimal viewing experience tonight. This webinar is being recorded. We do like to share our webinars with folks who couldn't be with us this evening. So I want to let everyone know that we are being recorded this evening. Please be sure that you keep yourself on mute. We have muted all participants upon entry, but would like to remind everyone to keep yourself on mute so any background noises don't distract from our presentation. Also, at the end of tonight's webinar, we will have a Q&A session. Some questions have been submitted prior, and we thank those of you who submitted questions, and we will answer as many of those as we can at the end. But if you do have questions that come up throughout the presentation, please feel free to use the chat feature, which you can find located if you hover your mouse over the bottom of the screen. There's a little icon that says chat, and you can submit any questions you have via the chat feature at any time, and we'll add them to the list for the Q&A. At this time, I would like to welcome our Executive Director of Alumni Relations and Development, Kenneth Lamb.
Thank you, Jennifer, and thank you to all of the alumni and friends who are with us tonight on this webinar. I just wanted to also say that I cannot believe that it's been a year since tonight's guest speaker helped to kick off our FDU Alumni webinar series last year with a discussion on COVID-19. A lot has changed, a lot hasn't changed, and there was so much unknown with last year in terms of COVID, and Dean Alvatroni did an amazing job helping all of us gain a deeper understanding of this disease that many of us really didn't know much about. And I'm very grateful and thankful to have Dean Alvatroni back with us tonight to provide us with an update and an outlook on where do we go from here. It's been a year where some of us have been in lockdown and haven't really gone out. We're all masked up and protecting ourselves. Where do we go? And what's the outlook like? Dean Alvatroni earned his BS in chemistry from FDU in 1999. He would go on to earn a master's and a PhD in chemistry from Princeton University in 2001 and 2003, respectively. Following the state's approval of the School of Pharmacy at FDU, Michael Alvatroni served as the Associate Dean of the program. He would go on to be named the Dean of the School of Pharmacy in 2013. Today, the pharmacy program has a 95% retention rate and only admits about 80 students per semester. The mission of the program under Dean Alvatroni is to prepare students so they are practice ready. In other words, upon graduation, the students will have the knowledge and skills, professionally and socially, to practice in the community, hospital, or in research. The School of Pharmacy has grown under Dean Alvatroni's guidance. It's now called the School of Pharmacy and Health Sciences. In 2019, the school began to offer a master's in public health. Starting in August 2021, social work will be a program available. And in 2022, occupational therapy is expected to start in August 2022, and the physician assistant program in January 2022. Dean Alvatroni is one of our star faculty and administrators on campus, and we're all fortunate to have him here with us tonight. If you ever get a chance to sit in on an open house for the School of Pharmacy, if you know of anybody, I would highly recommend signing up for one of their open houses. Dean Alvatroni does an amazing job welcoming students and families to campus, and they'll get a chance to see him in action, just as we are tonight. So with that, Dean Alvatroni, I pass the screen on to you.
Thank you so much, Ken. It's a pleasure, and thank you all for being here tonight. I look forward to being able to have the opportunity to talk to the group here and talk to you, although, as I think Ken was alluding to, it's hard to believe we're 1 year in. I thought it was an important look right now at where we are, where we're going. Ultimately, I think that what we've seen is that there's a lot of good news on the horizon. I think a lot of things that we should certainly look towards the future to try and get an optimistic view of the perspective of what's next. But I also think that it's important for us to take a look at a little bit of a retrospective of some of the things that we've done right and some of the decisions that we've made that I think have really challenged our view of public health and have challenged our view of how we manage something like a pandemic in the current climate of some of the challenging environment that we currently are dealing with. And so first thing I want to talk about, and I think this is an important factor that I think has really tripped up a lot of our public health view of the pandemic, and specifically our view of how the pandemic has been handled and how we can sort of take ownership as a society of the things that we should be doing and the things that we shouldn't be doing, and looking most importantly at how to navigate science going forward in what has become a very polarized and a very soundbite driven society. The first thing I'm going to say here is ultimately that the catastrophic outcome of what we've seen over the past year has been the result of a very serious disease. That is something that I will continue to come back to, that COVID-19 is a serious disease. It is something that has severely affected many people, particularly those who are elderly and those with underlying conditions. And it's not something that we should ever look to downplay. That being said, I think that one of the things that we've been challenged by is that COVID-19 has been used in many cases from all sides as a political weapon. And one of the things I'm going to stress here is that if by the end of this discussion, you know anything about my political views, about any type of party affiliation or any specific leaning, I have failed miserably as a scientist. This statement holds true for the next hour, and it should hold true anytime we are evaluating scientific data. Ultimately, science and the data behind it is apolitical. Trying to take ownership that one side or the other has a cornerstone on the facts is incorrect, and it shuts down a lot of important discussion that we should constantly be having when we're looking at anything as important and in some cases as dangerous as something like COVID-19. Ultimately, I would argue that the same litmus test should be held to every scientist out there that's responsible for presenting any data on this subject or any subject related. And the sad reality is that much of what we've known about viruses for decades, if not centuries, have been ignored as a result, in some cases, of oversight, and in some cases of what I would hate to say is reality of making things into a kind of a political football or a political weapon. And the results have frankly been tragic. And much of this ignorance has been an attempt to prove a political point. And ultimately, over the next hour, my goal is to present you facts only. I'm going to present a lot of raw data. I'm going to present a lot of raw data that is in fact validated and has been verified. And ultimately, what I would argue is that you as citizens should be able to make your own conclusions and make your own decisions with what you see and what you know, and should ultimately use them to guide a lot of the decisions moving forward for how you live your life. I've taught a lot of science students throughout the years, and many times I would be teaching students who were non-majors, who had to complete a science course just to be able to get a degree in something else. And I would always tell them the same thing, which was very simply that it was not about anything that I was teaching in that course that was so fundamentally important. If I was teaching the periodic table, it really frankly didn't matter to a student there who was majoring in literature or dance or communication studies, whether or not they remembered which element went where. But what I was trying to teach them was that being a good citizen means understanding and navigating the data that you're presented and helping use the knowledge that you have and that you gain to be able to make effective decisions about your life. And so whether we were presenting arguments about global warming, or we were presenting arguments about fossil fuels and the dangers of or concerns about them, whether we were presenting something on a pandemic or something about new sources of green energy, ultimately the goal in all of these things is to present arguments around the data and to allow people to be able to utilize that data to make good decisions. So the one other thing I will tell you is that I do believe that we have seen a pandemic that has taken place in the midst of the two greatest challenges of our time. One of them is the extreme polarization of our society, which is probably, as many historians would say, at what's probably one of the highest points of polarization since the Civil War. And when we look at that and we overlay that with the advent of social media and the access that people have to information, we are witnessing what is truly the best and worst of public health through social media. What you'll see in a lot of my presentation tonight are in fact graphs that I've grabbed or have obtained from people who have presented them on social media platforms like Twitter. That being said, I went back and verified every one against raw data to assure that the graphs that were depicted were factual and were accurate. I don't know how many people, when they see something, are doing that. And as a result, they look at things and cause either a panic on one side or the other. And oftentimes that leads to a lot of the game of telephone, where somebody says, I read or I saw, and next thing you know, someone who's got hundreds of thousands of followers has produced something that they are portraying as fact, that in fact is actually fiction. This is, I think, also, again, extremely played out in the fact that social media creates an environment where there's unintentionally or intentionally fear, stress, anxiety, and this sort of misinformation fountain that sometimes grows as a result of one thing that leads to another, that somehow translates to fallacy over the course of time. And ultimately, the one thing I would say is that we suffer greatly right now in the fact that our scientific and health illiteracy is a huge challenge. Many people struggle with the ability to be able to look at graphs and data and other things and make heads or tails of them. And the fact is that we've seen drop-offs over the years in math scores and science scores that are now the result of problems here when we're trying to make cogent arguments around things that are oftentimes at odds with fact. And I think this is a very important thing that we have to get back to. That rather than fundamentally teaching a lot of what we teach in the math and science realm in our middle school and high school and college curriculum, maybe we need less focus on advanced calculus and more focus on statistics. Because the reality is that while calculus is useful for a small portion of the society, statistics is useful for everybody all the time. Stats are all over the place, and being able to interpret them and understand them is critically important, particularly as we look at what we're going to look at tonight. That being said, I want to start off with some good news. And again, I want to start off with it amidst a sobering reality, which I will keep coming back to. Anything I'm presenting tonight in terms of signs of encouragement or signs of, in some cases, some second guesses on some of the decisions we've made all along is not in any way intended to downplay the reality that there has been a great impact of COVID-19 on our society. There's been significant loss of life, which I'm sure many of you have seen. We've now surpassed 500,000 who have lost their lives to COVID-19. There's been a significant impact on lives and livelihoods. So while we look at anything that will encourage us, or that anything that, again, will be able to look at and question, it's not meant in any way to downplay the reality of the fact that this is a very serious foe that we've been fighting for now over a year. That being said, the graphs show the story, and the story is a very positive one. We are currently looking at a significant downturn in every metric and trend that you would want to look at in measuring how well we are ultimately seeing control of the virus. On the left side are our nationwide metrics on a 7-day average that I just pulled from data this morning, which you will see shows a significant downturn on every metric, including cases, hospitalizations, and deaths. On the right side, you'll see presentations closer to home. These are statistics pulled from the COVID dashboard of New Jersey as of this morning. You'll see that we have a significant downturn in cases. Hospitalizations are at a low that hasn't been seen since November. We are probably set tomorrow or on Thursday to go below 2,000 hospitalizations, which is a significant milestone that hasn't been seen since the fall. And critically important as well, patients in ICU and on ventilators have dropped off significantly as well. One other thing worth mentioning in the upper right-hand corner, in a population of about 6.7 million eligible for the vaccine who are 18 plus in the state of New Jersey, we've seen about 1.1 million of those people who have received at least their first immunization, and another 500,000 have received the second immunization, which means about 1 out of every 6 people has some protection from COVID-19 through immunization. What I want to point out and stress, however, is that the trends you are currently seeing have very little, if anything, to do with vaccination, which is actually an encouraging thing, because we know that that will mean that things will continue to get much better, much more quickly. What I want to point out as well is a very interesting graph that you'll see here. One of the things you'll notice is that this is in fact an overlay that I believe was produced as of data probably from this past Monday that shows that if you overlay every climatological region in the United States, you will see the exact same pattern overlaid over the past several months. What I want to point out is that this is an important graph for two reasons. It shows a trend line that should be encouraging throughout the 50 states of the US. And in fact, if you laid graphs from elsewhere across the world, you would see very similar things as well. But what it suggests is that we need to look further into the story, because what you'll know is that there are very different guidance documents and parameters placed in all 50 states and all regions throughout the US. What we know is some require masks, some have had hard lockdowns, some have closed restaurants and bars, others have opened bars, others have opened restaurants, others have had the Super Bowl, others have had sporting events. But yet with all of those things that have changed in terms of the parameters that we see that people live with day to day, the trend lines have followed exactly the same, almost verbatim. And I think that's an important thing for us to keep in mind as we take a look at some of the issues around some of the action steps that we've taken to get to where we are and how we need to look forward. One of the other things I want to mention here that I mentioned just a moment ago, which I think is an important piece, is the fact that we are looking at, and there's been a lot of discussion around herd immunity, which is often a term that's talked about regularly amidst the pandemic. But I think it's important to say two things. First of all, it's not a bad word. People have talked about it saying, if you allow herd immunity to run its course, there'll be all of this collateral damage. I don't think that anybody at any point in time would say take no precautions, but herd immunity is a reality for us that has managed diseases and particular viruses throughout history. The other thing I want to point out is that herd immunity doesn't switch on and off, meaning that gradually over time, you may not see full herd immunity, but you will see reduction in cases as a result of shutting down what would be called vectors of transmission. To show you what I mean, here's an illustration. On the left is what we would be looking at early on in the pandemic, where a person who was contagious might surround themselves with 10 other people who would be considered as vectors of transmission because all of them would be subject to getting the disease if the possibility happened where they were in close proximity and certain parameters, which many of which we still don't understand, happened as a result of this disease transmission. However, what we have to remember is that herd immunity doesn't just occur from vaccination. In fact, there was a lot of misinformation that was produced that suggested we needed to have 70 to 80% of our population vaccinated to receive herd immunity and the benefit therein. That is factually inaccurate. Anyone who carries antibodies or T-cell immunity from COVID also presents as a vector of shutdown from transmission. And so what we're looking at now, which is probably close to where we're getting in terms of percentages, if you're looking at population, and they've said somewhere, there are studies out there that are looking at the fact that there's somewhere on the order of 50% of people who may have had COVID and are currently carrying either antibody or T-cell immunity. And as a result, those people are shutting down this vector of transmission because, as you know, with a very rare exception, people don't get infected twice. And so if you look at a number of people carrying the antibodies and a number of people who have been vaccinated, you take a look at 10 vectors of transmission on the left that now become 2. And as a result, what you know already is that with less vectors of transmission, less probability of propagating the disease further and further. And as a result, you see what's called a Gompertz curve. A Gompertz curve basically looks like an S, where the S starts to slow down towards the end in terms of a new case rise. In fact, that would explain what we have been seeing in recent events as a result of this exponential drop-off over the past month, which some are projecting is almost to a 40 to 50% drop-off nationwide as a result of the peak sometime in December or January and what we're looking at now. So that's something to be very encouraged by, and something that I believe tells a very captivating story in terms of us looking forward with significant encouragement towards the future. But one of the things that I want to suggest here is that one of the challenges of this pandemic, and one of the things that we've struggled with from the earliest days, has been rather than using data, we've used models. models have been a very, very significant source of a lot of bad decision making. And I want to show you an illustration here of the fact that oftentimes models became the public health narrative. And what we found was that ultimately poor decision making imposed significant collateral damage because we made assumptions from models that never played out in fact. Here on the left side is in fact several models that were overlaid onto a graph that showed specifically in the last 3 months these were produced by the state, what would happen in terms of a moderate and a high case scenario in terms of hospitalizations. The orange and yellow graphs that you're looking at were in fact those two projections, which showed hospitalizations peaking somewhere on the order of about 9,000 hospitalized at the apex. What we saw was that we never actually hit 4,000. So as a result, most of the projections that we were making were so flawed that in fact they led to extreme decision making that oftentimes produced things that were consequences that were ultimately, in some cases, worse than the outcome that would have been had we not adjusted for them. Here's another snapshot from New York's data. This was in fact produced in one of the governor's reports that showed the vectors of transmission, which in fact showed that about 74% of disease transmission occurred through household and social gatherings. And if you look down, way down on the curve of what would be considered as transmission vectors, you'll see that schools were on the order of less than 0.5% of the transmission. So what we chose to do was we chose to lock down schools and shut down schools because of a 0.5% probability. You'll see restaurants are there at about a 1.4% probability, and most restaurants in New York were completely shut down. What I want to point out is that everything has consequences. Certainly there are consequences to putting people in a high-risk environment, a restaurant or a school, if it were indicated to be a high vector of transmission. But there are consequences to shutting down restaurants or bars or schools or anything else. And those are the people who work there, who rely on them for their source of income, or the students who go there and rely on them in some cases for their learning, but in some cases for much more than their learning, for meals and for protection and for other things. And so data should have been the driving force of what we were using to ultimately make our decisions. And in some cases, using these projections and projections that were not grounded in fact led to decisions that oftentimes had some significant collateral damage. And what I hate to say is that sadly, I don't believe we've seen the first wave yet of the collateral damage of some of these effects. And I'll talk a little bit more about that in a moment. One more thing I wanted to point out was that you'll see here several statements within a paper published from the International Journal of Forecasting in August of 2020 that actually showed some of these projections and how errant they actually were. You'll see here, for example, which we heard and very regularly referred to because it's close by, the state of New York saying that they were going to need 140,000 hospital beds, 40,000 ICUs with ventilators. And in fact, they were modifying that when they looked at reality, that they only were hospitalizing, and I say only sort of again, just in comparison, 18,000 versus 140,000. You look at the state of Tennessee and a projection of 15,500 inpatient beds, 2,500 ICU beds, and 2,000 ventilators. The real numbers, 1,232 instead of 15,500, 245 instead of 2,500, and 208 instead of 2,000. So we're not even off by a factor of 1 or 2. We're off by factors of 5 and 10 and 20, which is pretty significant. The other thing you'll see here in the lower left, a reference to some media blitz that was talked about when they were going to reopen the state of Georgia. And they said that lifting the restrictions in the state of Georgia would result in over 23,000 deaths over the next month. And the projection instead, 896. And again, not to downplay by any stretch the fact that any death is obviously a significant one, but when you're using projections and you're talking 23,000 and you find 896, I would argue that any scientist anywhere would say that that was a very terrible experiment that was done. And I think that's something we need to look at. On the right, what you'll see as well were some of the impacts that we're still seeing and will continue to see on hospitals. stopping of elective procedures, delays of treatments like chemotherapy and radiation. Those were damaging in terms of just shutting down people from treatments that they needed to be able to recover or stay alive or manage chronic conditions. Another thing that we're going to see that's a collateral damage piece here is that many hospitals, when they were shut down from seeing patients for these other disease states or for elective surgeries or others, had such a financial hit that they had to lay off significant numbers of employees, which meant now that there are less people there for when we need the care who are currently employed by these health systems. So significant downturns in these projections being so flawed that are outcomes that really ultimately are going to hurt us for many years to come in some cases. Another thing that I'm going to say here, and I'm going to say this in a very harsh way because it's a very stern reality, we sacrificed our children for our elderly, and if you look at the data, we failed them both. And what you're going to look at here are some snapshot headlines that I see and I personally get horrified by. The coronavirus seems to spare most kids from illness, but its effect on their mental health is deepening. Child suicides rising during lockdown. And in fact, in Clark County, Nevada, which is the home to Las Vegas and other towns therein, they actually were so alarmed by the fact that they had over 3,100 alerts to district officials that the superintendent issued an apology saying he had failed the students and immediately reopened the schools. They're projecting that stats based upon what they've seen, over 275,000 allegations of abuse and maltreatment of children went unreported during just the 3 months of the pandemic in March, April, and May when schools were shut down. And then closer to home, Monmouth County, just a headline last week, again, just to point out the fact that this is not sparing certain people and not others, Monmouth County is the third most affluent county in the state of New Jersey and one of the most affluent counties in the United States. A girl of 8 years old, trembling and fidgeting on the Zoom call that she was attending school in. When they delved into it a little bit more, found out that she hadn't eaten for days and her entire family had no access to food because her mother had been out of work for months. Those are things that when children are in school are picked up by the teachers and the caregivers that are there. When students are not around to be able to be seen and known by the people who care for them, bad things happen. And I'm afraid that many bad things have, and many more bad things will. Just to point out, on the other side of why I said we've also failed our elderly, statistics suggest that 1 out of 8 beds in the state of New Jersey is now empty within skilled nursing facilities as a result of people lost to the pandemic. You'll see the stories here that in fact empty beds are everywhere. But one of the things that I really kind of am horrified by is that you heard early on that there were a lot of impacts to nursing homes when we didn't know a lot about the disease. Well, the statistics in this table show that in fact a 45-day increase from November 15th to December 31st showed the number of outbreaks that increased over the course of those 45 days in skilled nursing facilities. And you'll look and the percentages are in the hundreds. And in fact, right now, as we look at the COVID dashboard in New Jersey, we look at over 300 active outbreaks in nursing homes that are currently taking place, in spite of the fact that we know what we know about how to manage the disease. We know what we need to do in terms of quarantine and trying to shut down this vector of transmission amongst the most vulnerable. And yet it hasn't been done and it's not being done. And even when you look at our vaccine rollout in the state, rather than prioritizing those who were the highest at risk, those who we know had the poorest outcomes, we in fact didn't do that. So it looks right now that the 75 plus population in the state has received a lower proportion of the population's vaccines than those who are under 75, in spite of the fact that we know the magnitude of risk for those who are the most infirm or the most at risk. And another alarming statistic of where we're going that I think is going to be a devastation to the population of elderly within the state and within the country, they project that unless there's some sort of a major bailout, 2/3 of nursing homes are at risk of closing in 2021. And just think about what that does and what that does to the people who reside in those homes and the caregivers who rely on those people to care for loved ones who can't be managed at home. Imagine the collateral damage if 2 out of every 3 skilled nursing facilities in the nation can no longer exist any further. A very alarming statistic, and one that suggests that a lot that we've done here has really put both our young and our old at significant risk. Another thing that I'm very fearful of is that we're losing a generation, and the statistics everywhere show that. Here's a report from McKinsey & Company that was produced as a result of looking at student learning in the United States. And here are some statistics that show that not only is this risk great, but the disparity between those who are in high and low income and racial majority and minorities is alarming, and it's horrifying to look at. In fact, if you look at the quality of remote instruction of K-12 students and look at the graph at the top, in the low income population, 40% are projected as having no instruction during this time. That's not just saying we're trying, that's saying we're not even attempting. And if you look at the low income projection of lost learning versus in classroom, the projection is twice as great as the average overall that's expected to be lost as a result of disengagement. What does this look like? This is damaging to a point where we're going to see this for a generation as follows. The projection, scenario 3, if in-classroom instruction does not resume until fall of 2021, which for many of us is what it's looking like, the projected loss of the GDP of this nation is between $306 and $483 billion, with a projected annual earnings loss between $169 and $221 billion, and 1.1 million additional high school dropouts projected. Again, the people who are most at risk are also the people who have the least in terms of access to the things that would be provided to help them to be rescued from this situation. So you're seeing that not only does it hurt everyone, but it astronomically hurts with a much greater affinity those who are the most at risk to begin with. And here's the most alarming statement, not what it says in the top, but what it says in the sidebar. Early data on learning loss show big drop in math, but not reading skills. And you say, well, okay, maybe there's some encouragement there. Big asterisk. Many missing low-income students didn't take the test this fall. Imagine the fact that we are now referring to the fact that many of our students are missing. And just think about what that does in terms of the consequences moving forward for our society. Where do these people that are missing end up? And one thing, and speaking with someone who I was talking with who has a significant impact in inner city implications for education, was talking about the fact that while we all may have gone into a lockdown, gangs and others who are drug dealers and others haven't gone into a lockdown. And they are right now preying on a generation in the inner cities. And in many cases, they're winning because they are the only ones out and around who can play an impact in this role while everyone else has sort of gone on hiatus. And that's also a horrifying thought of what's going to be in terms of a generation of lost youth. One other thing I want to sort of point out here as I'm bringing this all to your attention, again, I want to talk about the fact that as we're looking at data here, we're looking at trying to analyze in sort of a retrospective to help us make better decisions as we move forward. What does this all look like for us? And has the impact ultimately moved the needle on being able to get us to a place where we're more effectively able to manage the pandemic? Because then you can argue it's a sacrifice, but it's a trade. This graph on the left shows you something that I suggest would be pretty discouraging in terms of indicating that, in fact, the lockdowns that we've imposed have made any difference at all. If you followed world media in terms of how the two sort of examples in the first world of the two extremes of trying to manage this disease have been Sweden and the United Kingdom. Sweden has been the benchmark, for better or worse, for what to do in a sense of not imposing all of these parameters of lockdown and restriction. They have left schools open. They have largely operated as though they've been kind of business as usual with some restrictions, not to say that they've done nothing. The UK has locked down multiple times, has in fact been locked down regularly since before Christmas, and has shut down every aspect of society and life. And what you'll look at here is that, in fact, this is the case per million graph normalized for population. So this is an apples to apples comparison. And the graphs basically overlay on one another. And the point that you're looking at when this graph ended, which was 121, the two lines overlay identically. So what that suggests to me is that we have to question whether or not all of the things that we've been doing are in fact things that are wise to do when we know the consequence as a result. Domestically, here's a snapshot of 4 examples of what we can look at in terms of the real extremes. Overlaid on the graph is Florida, California, New Jersey, and New York. You know that California has been an extreme case in terms of lockdowns, with the most restrictive environment there since the pandemic really began. On the bubble here on the left, which is difficult to read and it's not intended to be read, shows some of the parameters in which there are lockdowns in the overall sort of evaluation with regard to schools, with regard to the limits on gathering sizes, with regards to gyms and fitness centers, bars and taverns, indoor dining, places of worship, and so on and so forth. It's a comparator therein. You'll see that the extremes are such that California, New Jersey, and New York are similar in terms of having imposed significant lockdowns, while Florida has gone almost the other extreme and has really been open by and large since September or thereabouts. And what you'll look at when you look at the hospitalization census, ultimately it's no comparison. But ultimately, it's no comparison in the wrong direction. That Florida's hospitalizations are significantly lower than New York, New Jersey, and California. And this is not age adjusted, which is even more significant, because if you think of Florida's population, Florida has one of the highest elderly populations in the nation, if not the highest. So the extreme should be the other direction, that in fact, the most vulnerable should in fact be the ones who are highest risk, and an environment of uncontrolled regulation should be exacerbated even further if those risks are in fact a real danger. So it's a concern here when we look at the data, and it's a concern here that we need to monitor and look at. And another piece of data that I'll show you that suggests a similar thing. This is from the American Academy of Pediatrics, comparing the percentage of schools that are currently open in the bar with the number of cases per million for pediatric cases, per 100,000. And what you'll look at ultimately is Florida, Ohio, Illinois, and California as the 4 data points. And what you'll see is that Florida has had 99.8% of its schools open. California has had 5.4% of its schools open. And the pediatric cases per 100,000 are higher in California than in Florida. A real concern when you look at the statistics combined with those statistics that I presented before on the collateral damage that school lockdowns have done on our youth. I think it's something we need to really look at and evaluate in making decisions the right way. Another thing that's shown in international data and literature, here's an excerpt in a paper that shows that in fact, the vector transmission of peer-to-peer inside a school for young people is about 1% in a town in Germany or an area of Germany when they did specific close contact monitoring. And in fact, what they found was that the highest risk was teacher-to-teacher transmission. That was in fact the highest risk of vector transmission. And as a footnote, this particular area that was studied did not practice social distancing and did not practice masking of students. So you couldn't even argue that in fact they were following the extreme protocols. Again, I'm not advocating for or against. I'm simply just presenting the reality that this data suggests that schools are not vectors of transmission, that young people to young people is not in fact the way this disease spreads. And I think it's important for us to know that, because it's important for us to use this information wisely as we plan for our future of what's next with regard to managing COVID. A couple of things that I think are interesting as I'm sort of looking just in overviewing some more critical pieces of this. We chose to ignore seasonality for some reason. We've known about seasonality in terms of pandemics from flu data that we've had. This is a paper published from 1950s, published in the early 70s by Dr. Edgar Hope Simpson, which in fact shows how pandemic viruses spread in the different zones of the world, from the temperate to the tropical in the northern and southern hemispheres. What you'll notice, in fact, is if you overlay this as well on data from the pandemic of 1968 to 1970, often referred to as the Hong Kong flu, and then you look at the curve of what we have now, where in the white box here is if you combine the temperate and tropical regions and made a Hope-Simpson graph, and then you looked at the graph of COVID transmission versus the graph of the Hope-Simpson and the graph of the 68-69 pandemic of flu, the graphs are almost identical. That it suggests that the biggest parameter by which we are seeing disease management is in fact transmission reduction due to seasonality. That in fact, it's always been known that January should be an apex for coronavirus transmission, and that it starts to drop off in February and a little further in March, and then ultimately in April, May, and June starts to drop off further. And it's remarkable how this graph overlays almost identically onto the SARS graph for the current pandemic versus a historical graph that's almost 50 years old. Another thing we should have known, also from Dr. Hope-Simpson, everyone had this sort of panic about a twindemic, that we were going to see that flu was going to take over where the COVID virus was running rampant and create this twindemic that was going to overrun hospitals and health systems. What we notice here from the graphs, flu is gone for right now. It has disappeared. In fact, it has a 0.1% positivity rate as compared to what would normally be for this week of 21%. And if you look at a publication from 1957, from the transmission of epidemic influenza, what they talk about, in fact, was that he references, Dr. Hope-Simpson, the vanishing trick, which in fact shows that only one virus can simultaneously spread at the same time. When one virus dominates, the other goes away. And it's a pretty remarkable thing that we've seen, which is, again, something we could have learned earlier that would have helped us to make better decisions about what we've done and what we're doing. Ultimately, we see here, I think, a pretty remarkable document that I've excerpted. Here are 6 snapshots, and I'm not going to read these, but they talk about the fact that there's little research on the impact of school measures on transmission, that home quarantine of exposed individuals to reduce transmission is not recommended because there's no obvious rationale, that contact tracing is not recommended, that screening travelers is not recommended, that masks, in fact, are not recommended, that reusable cloth face masks in particular, that work closures should be minimized and should also take into parameters with a study in depth of the collateral damage. And you think to yourself, well, what document is this and where was this pulled from? Because it seems counter to everything we've done and sounds like one of these sort of fringe documents that would be spreading on Twitter. Well, the unfortunate thing is this was pulled from the World Health Organization's non-pharmaceutical public health measures for mitigating the risk and impact of influenza, published in 2019. So this was a document produced 1 year prior to when we took all of these reactions to the opposite of what was in fact produced as a best practice document for us to follow. It makes us wonder as to what happened here in terms of, did panic ultimately make some rash decisions early on that gained momentum in a way that ultimately produced some outcomes that may have led to damage that we didn't even anticipate. One of the things I will say is that didn't help was, again, the fact that we do truly live in a soundbite society. So here's an episode that I think is a good example of what we'd be looking at as to why so many people get so panicked so quickly. Here's a headline from January 31st, why Rolling Stone magazine has deemed themselves the expert at a new COVID variant is questionable, but here it is. It says, epidemiologist warns a COVID-19 hurricane is coming. And here's a research-based study from King's College in London, published the day after. No evidence of change in symptoms from new coronavirus variant. And here are the graphs of 2 areas, Switzerland and Denmark, that in fact now have what was called the hurricane variant of B117, this extreme sort of strain of coronavirus that everybody was concerned about. It's spreading in 50% of cases in the top graph of Switzerland, and on the left graph, it's in Denmark, spreading about 40% of the cases. And what you'll see there is that cases are in fact dropping like a rock. Another study just published today, actually hit the presses probably right before we started here, suggests that this variant was actually spreading as early as September or October in California. And California's graph looks just like these does. In fact, probably almost steeper in terms of the drop off. The other thing to point out is that both Switzerland and Denmark did not lock down. So these graphs are not the result of a drop off through extreme measures. They're actually the result of a drop off that's the result of what we project to be probably the same seasonal effect we're seeing everywhere else. But here's one more snapshot published in the New York Times. Headline, this hit again social media and everywhere else where you would just see the headline unless you click the article. The virus variant spreading in Britain may make vaccines less effective, study shows. This is the context of the article. You'll see here what it says is, in fact, that the B.1.1.7 had no evidence that it would evade the vaccine's defenses. And then it says later on in the article, it's much too early to speculate whether it will, so we'll have to wait for the data. So the question is, how many read the headline and how many read the body of the article? And then do we wonder, is that why we made decisions that were questionable in terms of managing our disease outcomes? One other thing I want to point out, and I think this is a critical piece before I end on a little bit of a higher note in talking about some of the positives that are still to come. I say it this way, we're all in the same storm, but we're not in the same boat. So here's a snapshot of the fact that ultimately the struggle is very much bipolar in a sense of who's struggling and who's benefiting. Here's a statistical list of some of the beneficiaries of this last year who have seen their wealth grow significantly as a result of the pandemic and the corresponding decision-making. And you'll notice the names up there, like Jeff Bezos, who obviously has benefited from the fact that Amazon has become our mode of groceries and items for home needs and for purchasing things when we can't go out to the store. You'll notice names like Musk and Gates and Zuckerberg and others who are controlling a lot of the media in a sense of what's out there. And then you'll notice on the other side, here's what most others have experienced, like 73 million who lost work between March 21st and December 26th, 16 million collecting unemployment, 100,000 businesses permanently closed, 29 million reporting between December 9th and 21st that their household did not have enough food in the past week, and 14 million adults, 1 in 5 renters, reporting that they were behind in their rent. So what do we see? We've seen the largest transfer of wealth in the world history, and the results will be forever felt. The top 1% have taken $50 trillion from the bottom 90%. And here's what the previous recessions have looked like in terms of the impact. And here's what it's looked like during the coronavirus. Normally, the plateaus were about flat for the highest and lowest wage earners. Look at the graph during coronavirus and what's happened to the lowest earners and the impact therein. And so we start to question, higher income workers are less affected by unemployment. They're more likely to work from home. They're more likely to be able to afford support services for their children or for their families. They're less likely to need to leave their homes for work. And they're the decision makers around many of the policies of extended lockdowns, school closures, and elsewhere. So we start to question whether or not the decision makers have truly had a finger on the pulse of most people who have been greatly affected on the day-to-day, or have they been operating in a silo where they don't fully appreciate the impact that's being had when we look at these other things? And I think it's a significant question for us to ask. Again, in no way downplaying the seriousness of the virus, in no way downplaying the fact that we need to do things to manage it. These are things just to point out, to realize that there is no magic tonic here, that ultimately these are hard decisions, but we have to be asking questions and using data to guide us. Now to just end quickly on a silver linings amidst what we're seeing here. The first of these we already know. I referenced this a year ago, and we saw it play out over the past year, that in fact, it's been a remarkable scientific breakthrough and development, that vaccines have gone from clinical trial to development to inside people's bodies in under a year's time. Data from Israel, where there's been the most aggressive vaccination policy and the most aggressive vaccination campaign, shows very high encouraging data. In fact, close to 90% have received their first dose in Israel, and they showed significant drop-offs in those who have been vaccinated, needing hospitalization or medical care. And here's some of the data to show that in fact, you're seeing that over 98.9% prevention of COVID death, 99.92% prevention of serious disease, remarkable outcomes that are only to encourage us, because in fact, we know already that much of what we've seen is just yet the outskirts of the disease being managed by vaccines. So we should be encouraged by more encouragement on the horizon. Again, do we know fully that new strains will be covered by the vaccine? We don't. So let's wait and see the data and learn from it and adjust accordingly. But a lot of encouragement right now. Other treatment options have been another thing that oftentimes is a subtle piece, but you'll see here important study on the upper left that shows, in fact, simple increase in vitamin D levels by giving vitamin D supplements decrease mortality by more than 50%. The use of convalescent plasma has shown impact on lowering risk of death and severe manifestation of the disease. And we've seen monoclonal antibody treatments that have also lessened the severity in patients. It's why we've seen the death rate decrease so much from when we saw it last March and April to now. In less than a year, we've worked out treatment regimens that have made a significant impact on managing the disease, even in those who have had severe exacerbations. And that's been a tremendous thing. And again, kudos to all those who are on the front lines doing this work and doing this research and realizing these things in tremendous impact in such a short time. One other thing I want to mention before the final piece, which is that we've also seen expanded roles for health practitioners. As a dean of a pharmacy school, I've been excited to see that pharmacists have been such a commodity for the US as we've ramped up vaccine rollout, that in fact, they have been front and center to the immunization campaign and have been doing extensive work in these mass vaccination centers. And I believe a lot of this will return as we get to the other side to a new normal that will allow healthcare to be practiced in an evolutionary role for many of our practitioners, which I think will benefit all of us as a result. And you're even seeing things like telehealth and virtual health, which were unheard of before the pandemic, starting to become much more front and center. The final thing, and the brightest silver lining, hit the papers, I believe, on Sunday. Many of you have probably seen it. It's been backed up and validated now by reports from JP Morgan Chase, and also a report today by Scott Gottlieb, the former FDA commissioner, all of whom are echoing these same things, that we're seeing this drop-off, which in fact suggests not the typical drop-off that you would see as a result of a little bit of a management here or a little bit of a change there, but in fact looks much like the attainment of a herd threshold that may not be full immunity, but is suggesting that drop-off that I articulated earlier, which is where you're starting to see vectors of transmission so greatly reduced that you're in fact starting to see things move in a very positive direction. The person who wrote this report, I want to point out, is not someone who's either an eternal optimist in a sense of being kind of delusional, or is someone who's a fringe person. He's a professor at Johns Hopkins School of Medicine and the Bloomberg School of Public Health, the chief medical advisor in a number of places, and actually was bandied about under the Obama administration as becoming the Surgeon General of the United States. Couple of impactful things here that were pointed out that I think are critically important. One of them is that they suggest that what we know of as the illness rate has been underestimated, that in fact, there are many more people who are walking around right now with antibodies from either asymptomatic or low symptomatic transmission than we are currently counting, which gets us closer to that herd threshold. They also talk about the fact that a lot of people internally are talking about this, but they're trying to caution and not produce too much positive buzz in hopes that they don't turn down the rates of vaccination. The one other thing that's very important, because you've heard this talked about a lot, of how long will antibodies last, and are people starting to have their antibodies wear off, and other concerns about this. An antibody study that was done and referenced in this article from survivors of the 1918 Spanish influenza pandemic showed that in fact they still had long-term T-cell immunity 90 years later when this study was conducted in 2008. Can we say it's a guarantee that the same thing will hold true for COVID-19 in terms of long-term immunity? We can't say for sure, but I hope that during this presentation, I've showed you that we learned a lot through the years about viruses. And while we call COVID a novel coronavirus, it is novel in a sense of being new to our biology, in a sense of new to the immunological response of humans. But it's a virus and it behaves like every other virus we know and every other virus we've studied to date. So I think a lot that we've learned we can use in making good decisions moving forward to control the pandemic, to stop its spread, and equally important, to help us to get back to a navigation of our lives that helps to build back those pillars like schools and society, that helps us to manage the illness, but also manage our ability to live with it safely and effectively. And so I look forward at this point to fielding any questions that people might have. I thank you for your time and your attention, and look forward to a few minutes worth of questions to be able to tackle what's on people's minds.
Great. Thank you, Dr. Alvatroni, for such a great presentation and kind of taking us on the journey of where we've been and where we're going through this pandemic. We did have some questions submitted ahead of time. We also had some questions submitted via chat. We do recognize we are running near the end of our hour, but we'll get to as many as we can. And if you do feel the need that you have to jump off, because we may go a little bit past, we thank you for attending.
And one other thing I'll mention, my contact information is here. If there's a question people have, I'm happy to field via email anything that people may have, and I would certainly look forward to any conversations to follow.
Great, that's great, thank you. And actually, quite a few of the questions, even those submitted via chat, you were able to answer throughout your presentation. So hopefully for some of you who submitted, if we don't get to your question, it may very well be because Dr. Alvatroni already spoke to it. But we'll start with the first question here. And this is from alumnus Peter Harding. And Peter would like to know, are there any studies currently being done on the long-term persistent health risks from COVID infection, such as pulmonary, cardiac, or neurological damage?
There is some science out there that's showing what they would often refer to as long COVID. The question becomes, a lot of data still needs to be collected because obviously, as we know, this is still a fairly new disease. So studying long-term effects of something we've really only been able to monitor for a year or so isn't good at manifesting the data that we would need. That being said, what we do know is that there's a lot known about long-term viral effects that have been seen from things like even infectious mononucleosis, influenza, and other prior diseases where there are certain populations that in fact have long-term effects. And a lot of it is unknown as to why, again, much like what we see here, why if you take 10 people, do 8 of them show no symptoms, 1 shows a very mild symptom, and 1 shows massive effects. And it's not always about age. It's not always about comorbidity. So there's a lot more that needs to be done. But for right now, they are currently enrolling longer term studies to try and monitor this and to try and manage it as effectively as we can as well, so that we're being able to provide resources for people who are struggling even long after they should have recovered.
And would I be safe in assuming, Dr. Alvatroni, that some of the studies on the long-term health risks are going to be long-term studies where we might not know for many years what they are?
Many years. Ultimately, what I think we're still in the sense of the research on COVID-19, whether it be sources, whether it be the progression, whether it be even the decisions we've made, we're still in the second inning of a 9-inning game in terms of sort of the baseball analogy. There's so much we still don't know in a sense of what we've done, what the effects have been on what we've done, what we haven't done, and what the effects have been. There's still a lot more to come.
Great. Our next question comes from the chat, and this is from alumna Deanna Gray Maselli. Hi, Deanna, one of our past presenters for our webinar series as well. And Deanna's question is, besides not contracting COVID-19 post-immunization, are there any biomarkers that can be measured to reassure older patients that the immunization is physiologically working?
So good question. So there are a number of things, much like you can get a titer analysis in your blood of whether or not you still have immunological response to measles, mumps, rubella, which many adults will get prior to needing vaccines for follow-up for a job in a hospital or somewhere else. Similarly, you can have a biomarker test done to be able to monitor for COVID antibodies. And going forward, to be more in depth, you can also do a more expensive and extensive T-cell analysis test. Ultimately, the question is going to be whether or not the sort of risk versus reward there of needing an extensive battery of tests, when in all likelihood, for those who have been vaccinated, the response is going to be such that probably a simple antibody test would be accurate and adequate.
We have a couple, we probably have time for a couple more questions. And the next couple questions specifically revolve around the vaccine itself. What do you believe is the reason? Oh, let me first say that this question is from Carol Creekmore, who's an alumna of FDU. She's also a staff member. What do you believe is the reason for the slow rate of production for vaccine distribution?
So a lot of it is supply chain issues around some of the raw materials. Obviously, as you know, it's complicated to manufacture a vaccine, largely because there are a lot of raw materials which need to be produced together in such a way that there are also storage and shipment and expiration issues around those. So building up the supply chain is something that's kind of rate limiting right now, in a sense of raw products for a lot of the raw materials that are not necessarily the active ingredients themselves, but are those things which are stabilizers or are additives that would help the vaccine to either be able to travel or to be safe and in the pH of the body or so on and so forth. So a lot of it is not just the manufacture of the antibody itself, but of also the raw materials and the assembly line therein. Then there's also issues around, for particularly the Moderna and the Pfizer vaccines. Those need to be cold shipped. So there are storage issues around how much a shipping facility can manage in terms of how much it can take to be kept at a -80 temperature. So a lot of these things are complicated. The new J&J vaccine, which will be rolling out, is one that can be stored under ambient conditions. So that's going to open the door on a much more rapid rollout, in a sense of being able to get this not just to places that have the ability to freeze it and store it, but the ability to just have it in a sort of more neutral environment.
So there's no easy answer to that question.
No, the unfortunate part is that one of the things I do wish is that we did a better job in knowing from March till now that we were planning on a ramp up for a vaccine, having a better rollout plan, not just for supply chain, but even in terms of, as I was alluding to before, we should have had on day one these vaccines in every nursing home in New Jersey and in the arms of every resident. There should have been no wait. There should have been no delay. If we know that the over 75 population is so at risk, they should have been the first ones getting it.
I've heard those same sentiments before as well. So we have time for one last question. And I think it ties in a little bit to the previous question, because you, Dr. Alvatroni, you mentioned the different companies and the different vaccines available. So this question is from an alumna, Gladys Harris. And her question is, several pharmaceutical companies are in the process of introducing their vaccine, among those that have already been introduced. And the general public is very confused as to which vaccine would be best for each individual. As we know, there is different dosing protocols, potential short and long-term side effects. So any suggestion to our folks listening who plan to get the vaccine, if they have a choice, how to choose which one may be best?
So the long and short right now that I suspect everybody would probably echo is the one you can get is the one you should get, because as I'm sure you all know, New Jersey has got a waiting list, the likes of which, you know, the old Ticketmaster days of trying to get tickets to a hot concert have nothing on the current sign up for a vaccine. Ultimately, what I was alluded to before, the clinical outcomes are not terribly different in the Moderna and the Pfizer vaccine. Both are shown at over 90% effectiveness. One of the challenges is, as you know, both of them are a 2-dose regimen. the new J&J one that's not yet FDA approved, but is in the queue to be approved any day, will be a 1-dose regimen. Lower effectiveness overall, but very high clinical outcomes on reducing risk of severe COVID, meaning that COVID that would be exacerbated to the point of hospitalization or death. So one of the things I would suggest is ultimately a lot of it depends on availability. A lot of it will also depend upon, for those who maybe are at a lower risk, who want just the 1 dose without the side effects, which can be extensive in many people for the 2nd dose in particular, then maybe if you're at a lower risk, you would be willing to say, for 1 dose of a lower side effect vaccine, I'll settle on that one. Ultimately, it's something I would suggest you consult your healthcare provider about. They have extensive knowledge about this, but genuinely, I do believe right now, if you really are someone who believes very strongly that you're at risk and you can get access to a vaccine, don't question whether or not it's Pfizer, Moderna, J&J, or any other. Take it and know that you have that peace of mind.
Right. Thank you. Thank you very much, Dr. Avaltroni, for your presentation this evening. We're getting lots of positive feedback in the comments, in the chat, so I'm not sure if you're seeing it, but everyone really enjoyed your presentation tonight and found it extremely informative. So thank you. And I want to take the opportunity on the behalf of the Alumni Association and the Alumni Relations Office to thank everybody for attending tonight. And thank you to our sponsors. We have a new sponsor this season for our webinar series of TD Bank. So thank you to TD Bank for making these webinars possible for our alumni and friends. And please be sure to visit support.fdu.edu. This is where you can find the latest alumni news and updates, events, and more. Thank you again for joining us tonight. Thank you again, Dr. Avaltroni. Everybody stay safe and take care. Have a good evening.